Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. An interventional cardiologist at Upstate now offers a minimally invasive method of repairing a leaky mitral valve called MitraClip. Here to tell us about it is Dr. Ankur Kalra. He's an associate professor of medicine at Upstate and the division chief of cardiology. Welcome to the Informed Patient, Dr. Kalra.
Thank you for having me, Amber.
This MitraClip is not a new device. You've had experience with the MitraClip, which you've now brought to Upstate. How do you describe the MitraClip to your patients?
It's a device which offers what we call as transcatheter edge-to-edge repair. So the mitral valve has two leaflets. On what we call as a short axis view on a transthoracic echocardiogram, which is an ultrasound of the heart, where we can see the mitral valve. We often describe it to medical students or, first-year house officers as looking at a fish mouth. So it's got two leaflets to it, the anterior leaflet, which is the bigger leaflet, and the posterior leaflet, which is the smaller leaflet. And they've each got sort of three scallops, what we call them as three scallops. So they're divided into three sections and they coalesce to form one leaflet of that valve. So mitral regurgitation, which is the leakiness of the mitral valve, which we call as the fish mouth valve, happens not uncommonly and has different flavors to it. Just for the listeners, the mitral valve is the valve which is the conduit for the blood to flow between the left upper chamber to the left lower chamber of the heart. Many times it's what we call as a valve problem, and many times we call it as a chamber problem. So the leakiness of the valve takes different flavors. And this is important when, assessing patients for appropriateness of a procedure like MitraClip. So when I'm describing the device to patients, I tell them that it simulates a surgeon's stitch, whereby a surgeon can go in and, stitch the portions of the valve which are prolapsing into the left upper chamber, can stitch those portions together so that the leak is decreased. And from a fish mouth, we want to go to an owl's eye. So the goal is that after you repair the valve, it looks like an owl's eye with two orifices compared with the fish mouth, because the fish mouth is now leaky. And so the device is simulating the surgeon's stitch, just that it's not done through open heart surgery, it's done through wires and catheters.
So if I understand you, the valve, if it's the leaky valve, it's not, closing the whole way or sealing. And this MitraClip allows it to be the shape that it needs to in order to close all the way or seal.
Yes, so it's closing, but when it closes, it should not leak. And part of it is leaking back up into the left upper chamber.
I see.
So the clip is changing the configuration of how the leaflets interact with each other so as to decrease the amount of leakiness into the left upper chamber.
Is it an actual clip or is it like a paper clip? What does it look like?
It is an actual clip. So it's got arms and it's got grippers. If you end up touching it, it looks like a piece of sort of like tissue and fiber and sewn together. And so it is literally a clip. It looks like a clip on ultrasound, even, in its physical form outside the body. When we're going in with the clip, it literally is a clip with grippers and arms, which, appose each other and then can open and close.
Now, this is considered minimally invasive, but you still have to get this clip into the heart. So how do you do that and keep it minimally invasive?
Yes, great question. So it is minimally invasive. It is not open heart surgery. And, as you mentioned, the clip is inside the heart. It is putting the components of the valve which are prolapsing into the upper chamber in close proximity with one another, and it's holding those parts together. So it does have to go inside the heart. And how do we do that? We access the vein in the leg. It's called the right femoral vein. And through that vein, we dilate and put catheters that go all the way to the heart, to the right side of the heart. So that is the venous system. From the right side of the heart, we then puncture the structure which connects the right side to the left side of the heart. The right chamber to the left chamber, there is a structure in between. It's called the interatrial septum. So we puncture the septum to get into the left side of the heart. And then we appropriately, with several wire and catheter exchanges, get the delivery system inside the left upper chamber. And through that delivery sheath or delivery system, we then introduce the valve into the left upper chamber. And then that delivery sheath is steerable. So we have a lot of knobs outside, externally, which we play with, so as to direct the valve in the right direction. And this is done under ultrasound guidance. So there is a specialized ultrasound probe. It's called a transesophageal echocardiogram, which sits inside the food pipe. And that gives us great pictures because the heart is right in front of the food pipe. So under X-ray and through guidance from an ultrasound, we know exactly where the valve is positioned, and we can direct the valve to where we want to direct it to under ultrasound guidance, and then start maneuvering the sheath and the MitraClip, and then start what we call as gripping the different portions of the valve, which are prolapsing, and then assess live real time how those grippers have decreased the amount of leakiness before we release the device. So that's how we do the procedure.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with cardiologist Dr. Ankur Kalra about the MitraClip. Listeners may have heard about a cardiac stent device that opens the vessel if the vessel becomes blocked in some way. Is this MitraClip considered a stent?
This is how I explain the heart to patients, and I think it sort of makes a lot of sense for them. Think of the heart like a house. So the house has plumbing, the house has electricity, the house has brick and mortar, and the house has doors and windows. The heart is exactly like the house. And all these components in a house, the plumbing, the electricity, the doors and the windows, and the brick and the mortar have to work together for the house to be functional. And so the heart is exactly like the house. The plumbing is the arteries that run on the surface of the heart. And you mentioned stents. And so if there is a blockage in any of those arteries, the stents sort of keep the arteries open after we've addressed the blockage with balloon angioplasty. The electricity is the EKG or the rhythm disorders of the heart. So you come to a doctor's office, you get an EKG that only assesses the electrical component of the heart. It does not tell you about blockages. In the acute setting, it may tell you about whether or not you're having a heart attack. But if you have a chronic blockage, the EKG usually will not tell you, for the most part, that you have a chronic blockage. The EKG is assessing the electrical conduction system of the heart. The heart monitors assess the electrical conduction system of the heart. So you've got the EKG, then you have the doors and the windows of the heart, which are the valves. So the heart has 4 valves: the mitral valve, the aortic valve, the pulmonic valve, and the tricuspid valve on the left side and the right side. And then you've got the brick and mortar, which is the heart muscle itself. So if someone were to ask me, is this a stent? The answer is no, we're not assessing a plumbing issue. We're assessing a door and a window issue. So it is not a stent. It is a device which will fix a valve, which is leaky, which is, a door hinge which has gotten rusty, or, sort of a window which needs replacement. So that's how I put it together for patients.
Let's talk about the people who may be candidates for this, people with mitral regurgitation or a leaky heart valve. How would someone know that they have this condition?
So the most common symptom, Amber, is shortness of breath. So, if you're experiencing shortness of breath whilst performing activities which you would otherwise perform without experiencing shortness of breath, that is usually the first sign. The mitral valve is a little complex anatomically. It's got different components to it. It's got the leaflets. It's got the structures which attach the leaflets to the muscle It's got a muscular component as well, which are the papillary muscles. And then you've got these structures which attach the leaflets to the papillary muscles, and those are the cords. So depending on which component of the mitral valve may or may not become dysfunctional, you can either present with shortness of breath, which is sort of gradual and progressive, or you can present with sudden onset shortness of breath, depending on which component has gotten affected. And so that's why the treatment is variable or can be variable. So when you're having symptoms of shortness of breath, or if there's sudden onset of shortness of breath, usually with sudden onset, patients often present to the emergency department right away. So the way to assess it is to get an ultrasound, a bedside ultrasound, which we call an echocardiogram. Certainly do some blood testing, some biomarkers, which may be elevated because when the mitral valve is leaky, the blood is backing up into the left upper chamber. And from the left upper chamber, it backs up into the lungs. And so when that happens, we can draw biomarkers, a BNP in particular, which is brain natriuretic peptide, which is a hormone which is released by the heart muscle when the loading conditions of the heart are not ideal. And so a combination of chest x-ray and ultrasound and some blood testing, we can diagnose mitral regurgitation or leakiness of the mitral valve. And, we offer testing to these patients when they present to a primary care physician's office or a cardiologist's office with predominant symptom of shortness of breath. Now, you obviously can hear the murmur of mitral valve. Sometimes in acute settings where the leakiness has started like suddenly or immediately, you may not hear the murmur, which you do in patients who have chronic mitral regurgitation. So history, physical exam, ultrasound, chest x-ray, some blood testing, and then you come up with the diagnosis. And then, what needs to be done about it is a conversation with the cardiologist, sometimes with the surgeon, depending on patient's age. And sometimes we require additional testing before we can come up with definitive treatment algorithms or plans based on, what component is leaky, where is the problem. And that's where we do the specialized ultrasound. Sometimes we also get cardiac magnetic resonance imaging, which is cardiac MRI, to determine what the volumes look like.
Before we get too much more into the treatment options, let me ask you, are people born with mitral valve disease, or what causes it?
People can be born with mitral valve disease. Those are people who have what we call as congenital heart defects, where the mitral valve may be involved. That is usually picked up early on in a pediatrician's office. And a lot of these patients who have mitral valve involvement because of a congenital heart defect, the recommendation is to get surgical intervention performed. And the reason is because, in kids, they have the entire lifetime to live with a leaky valve. And so you want definitive surgical repair as your answer, compared with something minimally invasive, which is like a MitraClip, which is typically reserved for patients who are either at prohibitive risk or high risk for a surgical intervention. Um, and so, the answer to your question is yes, you can be born with mitral valve disease. Most common cause of mitral valve disease in the age group that we see as adult cardiologists is just valve degeneration, so mitral valve degeneration, which can either present as prolapse, it can present as calcification of the mitral valve apparatus, which would be a totally different treatment algorithm than offering them a MitraClip, because the leaflets are just too calcified for them to be gripped with appropriate, even satisfactorily. You can't just grip those leaflets which are calcified. And so that is a completely different algorithm. You need leaflets which are mostly either prolapsed or the valve, which is what we call is the apparatus, which is dilated because the chamber is dilated. You can still appose these leaflets together with a MitraClip. So the most common cause in adults is either we call it primary, which is a valve problem, which I alluded to earlier in the show, where it's the leaflets are prolapsing into the left upper chamber, or you've got the chamber problem where the left lower chamber is dilated, and because the left lower chamber is dilated, the mitral valve apparatus is dilated, which is preventing the leaflets to come closer to each other together. And so you can appose them using a clip. And we call that a secondary MR, or secondary mitral regurgitation, where again, clip in trials has demonstrated prolonging life for sure, and also preventing hospitalization with heart failure. Patients who should consider getting this device are not only patients who have a primary valve problem with a prolapsed leaflet, but also patients with chronic heart failure, where despite optimal medical therapy, they're still symptomatic. And if they have valve leakiness, particularly of the mitral valve, then they should be referred to a person like myself who can offer this device to these patients, because in the modern cardiology world, the MitraClip is now considered a heart failure device or a heart failure therapy.
Let's talk about the goals of treatment. If someone has mitral regurgitation that's causing them symptoms, what are the goals of the treatment? And then how do you help them decide whether they're a candidate for MitraClip or if they need surgery, or I don't know, is this ever treated just with medication?
So the answer is a little, I don't want to use the word convoluted, but it's a little nuanced. Because yes, the answer is that you can use medical therapy. It's sort of like we call it the pop-off valve. So if you can modulate or optimize the loading conditions of the heart, the leakiness will decrease. We use medications, what we call them as afterload reducing agents. So medications like a commonly prescribed blood pressure medication, lisinopril, or angiotensin receptor blocker, valsartan. And all these medications are also part of the heart failure management algorithm. So you start there and you optimize them with medications, and then you reassess to see what the degree of leakiness is. And if the valve is still severely leaky despite medical therapy, well, then the question is can the patient be offered surgical repair? And so you typically would have these patients be evaluated in a multidisciplinary heart team fashion by both an interventional cardiologist like myself and also with a cardiac surgeon, to then come up with a comprehensive plan as to whether a patient can be offered surgery versus a less invasive therapy like MitraClip. In heart failure patients who are otherwise optimized on medical therapy and still have valve regurgitation, like I've said before, we have randomized clinical trial evidence that MitraClip not only prevents heart failure hospitalization, it actually also prevents mortality. So in my view of how I view this device, yes, we use it for primary valve problem in patients who are not candidates for open heart surgery. We also use it in patients who have heart failure, who are optimized on medical therapy and still have a severely leaky mitral valve.
What would disqualify a person from a MitraClip procedure?
So is your question is like clinical indication for having?
I'm thinking, a lot of times people are told they're not a candidate for surgery because they have other health conditions. Is there anything like that that would disqualify a person from MitraClip?
No. It was particularly designed in patients who were considered surgically, quote unquote, inoperable or prohibitive risk or high risk. And, you would then offer these patients MitraClip because it's minimally invasive. You access the venous system and you are puncturing the septum to enter the left side of the heart. And then once the procedure is done, the clip is in place and you confirm it both through fluoroscopy, which is X-ray and ultrasound, before you release it. And then recovery is not protracted. Most patients, go home the next day. Sometimes patients require 2 clips. Sometimes they require 3 clips. You can start clipping or putting clips one, uh, it's sort of like a zipper. You sort of start putting the clips in line with one another until you are satisfied that you've been able to significantly decrease the amount of leakiness, not at the expense of then increasing the gradient across the valve, which would then be the other problem. Now the leakiness is gone, but the valve is too tight to open sufficiently. So it's a fine, striking balance between, okay, we've decreased the degree of leakiness, but not at the expense of the valve not opening now as efficiently as it should. In the particular case we did at Upstate last week, we were prepared to deploy 2 clips, but we got the results we wanted just with 1 clip. And over time, as clips mature and as more tissue develops around them, the cinch gets firmer or more mature, and the leakiness improves over time. So the other concept here is that sometimes you can still have residual leak after you've put 1 clip in. You can stop the procedure. You can follow these patients as outpatient clinically, get repeat ultrasound, say in 3 months and then in 6 months, and determine the degree of leakiness and also their symptoms, and then determine if they need an additional clip. But most of the times, I think you can get by with just putting 1 clip.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith, talking with Dr. Ankur Kalra about their MitraClip procedure for mitral regurgitation. How do you tell patients to prepare for the procedure? What do they need to know beforehand?
I think it's general precaution to, because this is done under general anesthesia, so not have anything the midnight after the day before the procedure. That's one. If patients are on blood thinners, and more often than not they are on blood thinners, because one of the common sort of heart condition that goes alongside mitral regurgitation is atrial fibrillation, which is a heart rhythm problem. So more often than not, they are on blood thinners for mitigation of stroke risk in atrial fibrillation. So we ask them to stop blood thinners for at least 48, if not 72 hours before the procedure, because this is a large bore procedure, so large bore device procedure. The size of the sheath is 24 French, 25 French. So we want to make sure that patients do not bleed excessively after we're done with the procedure. Those are the 2 sort of big ticket items in preparation for the procedure.
How long does the procedure last?
Leaning on what I told you earlier about using the number of clips, most of the times you can get by with just 1 clip. Sometimes you need to put 1 additional clip to stabilize the first clip or to decrease the amount of residual leak. If that's the scenario, it can last a little over 2 hours, sometimes 3 hours. If you look at the literature from the National Cardiovascular Data Registry and the Transcatheter Valve Therapy Registry, which is available by the American College of Cardiology, most procedures would typically last around 120 minutes, which is right about 2 hours.
Now, once the MitraClip is in place, can the person feel it or sense that it's there?
No. I mean, the person will feel, certainly will feel less winded, and the symptoms will abate, but they cannot really sense that they have a clip inside the heart. No, they cannot sense that.
What is recovery like?
Like I mentioned, a lot of these patients, once the effects of general anesthesia wear off, we want to keep them in-house the day they receive the procedure, to make sure that the anesthesia is worn, that they're stable from a vital signs perspective. Blood pressure is fine, their heart rate is fine, they haven't gotten into any funny rhythm, and then the access site looks okay. We want to restart the medications that they were on prior to the procedure. We want to make sure that they are tolerating diet properly before releasing them. So most patients would definitely have 1 night of hospital stay. And the idea is that most of them will go home the next day. So now sometimes for one reason or the other, patients end up staying longer. But for most patients, the goal is discharge on postoperative day 1, which is the day following the procedure.
And are they able to go back to all their regular activities right away?
Yes, for the most part. We obviously want them to be cautious. And now, again, this is not something which is like a high pressure access. What do I mean by that? We're not accessing the arterial system, we're accessing the venous system. So the venous system has more capacitance, so it's more forgiving in terms of if you were to strain or lift anything heavier, then you're straining the belly and the groin, and the pressure inside the vessels goes up. And if it's an arterial access and if it's a large bore access, which like I said it is, and it's eh, the access is recovering in a high pressure system, you definitely don't want patients lifting anything heavier than 10 pounds, for about a week. So we sort of extrapolate those recommendations even for patients who've gone through a procedure like MitraClip. Even though we are not accessing a high pressure system, we're accessing the vein, which has much higher capacitance. It's much more forgiving. It's low pressure system. But other than that, like, walking up and down the stairs, driving, doing activities of daily living, yes, patients can get back right away to doing all those things.
How long does the clip last? Because I'm wondering if there's ever situations where a clip might have to be replaced.
So the idea is for the clip to last the lifetime. Like I said, if there is more leakiness or if there is a residual leak and you feel that the patient may need another procedure, then you just go in and put another clip in close proximity to the first clip. But the idea is for the clip to last the rest of the patient's lifetime.
Now, is a valve repair or replacement possible if the patient ends up needing that later in life after a clip has been placed?
So great question. I think it will have to be a surgical intervention. And more often than not, these patients are getting assessed for what we call as M-tier, which is mitral transcatheter edge-to-edge repair. They're getting access for MitraClip because they were not surgical candidates to begin with. So I don't know if that answers your question.
They would have been assessed back before they even had the MitraClip then, and
Absolutely.
probably would not have been done if they needed a valve replacement or repair, right?
Yes.
So if someone listening to this wants to find out if they're a candidate for MitraClip, what would you advise?
If you have mitral regurgitation and you are symptomatic despite optimal medical therapy or maximally tolerated medical therapy, then I think having your primary care physician or your cardiologist refer you to someone like me who offers this procedure to patients, I think would be the next step. And then you may still not be a candidate for MitraClip. You may still be a good candidate for surgery, but I think you will then be appropriately guided to what's the next best step for you. Because we have a multidisciplinary heart team approach here at Upstate where patients with mitral regurgitation who are optimized medically are systematically evaluated by both a cardiac surgeon and an interventional cardiologist like myself to offer our patients what is the best treatment strategy or algorithm for them. The next step would be to seek referral to an interventionalist who can then start the multidisciplinary heart team approach for your management.
Well, Dr. Kalra, thank you so much for making time to tell us about MitraClip.
No, it's my pleasure. Thanks for having me.
My guest has been Dr. Ankur Kalra, an associate professor of medicine at Upstate and the division chief of cardiology. The Informed Patient is a podcast covering health, science, and medicine brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/inform. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.